Hello, everyone, and welcome to today's webinar, Exploring What's New Regarding Equity and Policy Preparedness for Public Health Emergencies. My name is Michelle Woods, and I'm the Program Director for the Homeland Security Program at the National Governors Association. In this capacity, I oversee the organization's public health emergency preparedness programs and activities. Today's webinar is hosted by the National Governors Association in collaboration with the Centers for Disease Control and Prevention and the American Bar Association, and is an update to our four-part webinar series on equity and policy preparedness during public health emergencies. The goal of the webinar series is to help state and territorial officials better understand the significant challenges to providing an equitable public health response to underserved and hard-to-reach groups, and to identify possible policy solutions. Previous webinars have focused on how responders can ensure equity and policy preparedness in the encouragement and enforcement of the mitigation efforts, distribution and uptake of remedies and resources, people experiencing homelessness, and people who are incarcerated. Each of these webinars can be found on our website. This work is funded by a cooperative agreement between the NGA and the CDC. The presentation content does not necessarily represent the views of NGA or the CDC, and the information presented should not be construed as legal advice or guidance. We appreciate everyone participating in today's webinar, and we have assembled a great slate of presenters who are working to ensure the equitable response to the ongoing COVID-19 pandemic and apply lessons learned to our preparedness for future public health emergencies. This public-facing webinar will provide you with an opportunity to learn from leaders across the public health arena about states and territories' efforts to meet the needs of disproportionately affected groups, identify legal barriers that undermine the equitable administration of public health countermeasures, and identify promising practices that can be used to address longstanding public health equity issues. Before we begin, we do have a few quick housekeeping items. As noted, this is a public-facing webinar and is being recorded. The recording will be available on NGA's website. Everyone has been muted upon entry to eliminate background noise, and we are holding all questions till the end of the webinar. If you would like to ask a question or participate in the webinar, which we strongly encourage, please select the Q&A function or the chat feature at the bottom of your screen. If you experience any technical difficulties, please contact Carl Amrit via the chat or at camritt@nga.org. We have a fantastic group of speakers who have agreed to join this webinar today and share their perspectives on this critically important topic. In the order in which we will be hearing from them, we have Dr. Jeffrey Hall, the Chief Health Equity Officer for COVID-19 Response and Deputy Director of the Office of Minority Health and Health Equity at the Centers for Disease Control and Prevention. Then we'll hear from Dr. Marcus Plesha, the Chief Medical Officer for the Association of State and Territorial Health Officials. Next, we'll hear from Dr. Jinling Chan, the Deputy Secretary of the Maryland Department of Health. And finally, we will hear from Don Hunter, the Director of the Southeastern Region Office of the Network for Public Health Law at the American Bar Association. As a reminder, we will have a question and answer period following the presentations. I want to thank all of our speakers again for joining us today. I am excited to hear from each of these experts, and I'm sure you are too, so let's get started with the presentations. Our first speaker comes to us from the Centers for Disease Control and Prevention. As mentioned, Dr. Jeffrey Hall currently serves as the Chief Health Equity Officer for the COVID-19 response and also serves as the Deputy Director of the Office of Minority Health and Health Equity. In these roles, he assists in the oversight of substantive health matters and in policy and program development. Dr. Hall, please take it away.
All right, thank you. Good afternoon, everybody. I'll begin our presentation with a bit of information to establish context for our conversation. Next slide, please. Over 40 million cases of COVID-19 have been reported since January 21st, 2020. Next slide, please. There have been over 650,000 deaths since January 21st, 2020. Next slide, please. We know that some racial and ethnic minority groups are being disproportionately affected by COVID-19. One way disproportionate impacts become apparent is by examining age-specific differences between the percent of the US population made up by different groups and the percent of COVID-19 deaths made up by each group. Next slide, please. For example, Hispanic persons make up 20.7% of the population aged 35 to 44, but almost 41% of the deaths in this age group. So the presented bar for those 35 to 44 years of age shows a difference of 19.7% between the proportion of the population and the portion of deaths made up by this group. Next slide, please. Data show that racial and ethnic minority groups are at an even higher risk for severe COVID-19 illness. As of July 16th, age-adjusted hospitalization rates are highest among non-Hispanic American Indian or Alaskan Native persons and Hispanic or Latino persons, followed by non-Hispanic Black persons, non-Hispanic American Indian or Alaskan Native persons, non-Hispanic Black persons, and Hispanic or Latino persons have hospitalization rate approximately 3.4 and 2.8 times that of non-Hispanic white persons. Other disparities are observed for cases and deaths as illustrated in the infographic. Next slide, please. It is key to focus not just on the previous indicators. We must also address factors contributing to increased risk of getting sick and dying from COVID-19. These include discrimination, healthcare access and utilization, and occupation, as well as educational, income, and wealth gaps and housing. Discrimination, which includes racism, leads to chronic and toxic stress. It also shapes social and economic factors, placing some people from racial and ethnic minority groups at increased risk for COVID-19. Occupation plays a significant role in this epidemic. People from some racial and ethnic minority groups are disproportionately represented in essential work settings, such as healthcare facilities, farms, and factories, as well as grocery stores and public transportation. Some working in these settings have more chances to be exposed to the virus that causes COVID-19. Next slide, please. The population health impact of COVID-19 exposed decades, if not centuries, of inequities, all of which systematically undermine the physical, social, material, and emotional health of racial and ethnic minority populations, as well as other population groups bearing a disproportionate burden of COVID-19. To accelerate COVID-19 disparity reductions, CDC established the Chief Health Equity Officer Unit. This unit's sole focus is to ensure an all-of-response approach to identifying and addressing health disparities. We developed the CDC COVID-19 Response Health Equity Strategy to address health disparities and inequities made worse by the COVID-19 pandemic. Next slide, please. We pursue 4 strategic priorities to reduce the disproportionate burden of COVID-19. We strive to increase understanding of COVID-19's impact and understanding of drivers and burden among disproportionately affected populations. We seek to expand testing, contact tracing, isolation options, and care to reach populations placed at risk. Third, we wish to better support essential and frontline workers to prevent transmission of COVID-19. Lastly, we seek an inclusive workforce equipped to address the unique needs of an increasingly diverse US population. Next slide, please. Data highlights groups at increased risk of COVID-19. These include, but are not limited to, racial and ethnic minority populations, people living in rural and frontier communities, people experiencing homelessness, and persons who are incarcerated or detained. Now, let's quickly cover selected examples of how we address the needs of such priority populations. We begin with the current project. In the spring, CDC began investing $2.25 billion over 2 years to address COVID-19 related health disparities and to advance health equity. The National Initiative to Address COVID-19 Health Disparities among populations at high risk and underserved communities, including racial and ethnic minority populations and rural communities, offered grants to public health departments to improve testing and contract tracing capabilities, to develop innovative mitigation and prevention resources as well as services, and to improve data collection and reporting. Grant funds were also provided to build, leverage, and expand infrastructure support, as well as to mobilize partners and collaborators to advance health equity and address social determinants of health related to COVID-19. Next slide, please. Regarding homelessness, over 500,000 people are experiencing homelessness on a given night. This includes over 200,000 each night experiencing unsheltered homelessness. However, many more people cycle through periods during a given year. Shelters in the United States serve 1.4 million people per year. Underlying medical conditions that can impact risks of developing severe illness due to COVID-19 are more common in people experiencing homelessness. As just two examples, diabetes prevalence is 18% among persons experiencing homelessness. This is in contrast to what is the case for persons in the housed population. Furthermore, hypertension prevalence is 50% among people experiencing homelessness versus 29% among those who are housed. Next slide, please. Hand washing remains a key mitigation strategy to prevent virus spread, but access to clean water, effective hand washing supplies, and restrooms can be challenging for persons experiencing homelessness. To address this need, the CDC Foundation, in partnership with the Clean the World Foundation, with financial support from Truist, and with technical assistance from the CDC, launched an initiative setting up hand washing stations and porta potties for individuals experiencing homelessness. These stations also provide service organizations outreach opportunities to connect with those currently experiencing homelessness. In Southern Nevada, for example, several sites serve as host locations to twice monthly pop-up events where up to 20 service organizations offer resources and support, including access to clean clothes, assistance replacing identification, substance abuse and mental health treatment, shelter, housing options, and more. Next slide, please. As a final priority population connection, let's address persons who are incarcerated or detained. Since March 31st, 2020, there have been slightly over 422,000 resident cases and 110,000 staff cases of COVID-19. About 2 12,700 deaths among residents have occurred, and 200 deaths among staffs were COVID-19 related. A study from the Federal Bureau of Prisons shows that people who are incarcerated are approximately 4.7 times more likely to get infected by SARS-CoV-2 and almost 2.6 times more likely to die from COVID-19 compared to the general population. And there's a publication that I can refer you to if you'd actually like to look at the findings of that study more closely. Next slide, please. As we all may recognize, there are unique challenges for correctional setting. As just a few examples, the virus that causes COVID-19 can be introduced into a correctional or detention facility from different geographic areas because staff and incarcerated or detained persons may come from a variety of different locations. In addition, space for isolation and quarantine can be limited, making transmission difficult to interrupt. Lastly, there is limited opportunity for infection and prevention control due to dense housing arrangement and shared hygiene facilities. Next slide, please. One excellent resource supporting COVID-19 prevention in correctional and detention facilities is freely available on YouTube. This presentation, as shown, elaborates the current context around COVID-19 and provides details regarding CDC guidance on creating long-term prevention plans, on applying CDC guidance for fully vaccinated persons, and lastly, on indicators for modifying facility-level COVID-19 prevention measures. Next slide. In addition, CDC works with other federal agencies and with entities such as Water Environment Federation to implement the National Wastewater Surveillance System. This is the first government-led wastewater surveillance program here in the United States. Wastewater surveillance provides a leading indicator of rising COVID-19 cases several days before clinically detected cases and with no individual clinical testing. Most notable, wastewater surveillance is also able to detect both symptomatic and asymptomatic infections. Therefore, wastewater surveillance can be extremely valuable in correctional facilities where close proximity can lead to large outbreaks. Want to see more relevant work? The Health Equity in Action webpage of the CDC highlights the work CDC is doing and organizations we are partnering with at the state, local, tribal, and territorial levels to advance and accelerate health equity. The page links to COVID-19 data that are critically important for assessing health disparities. In addition, it provides useful COVID-19 health equity resources such as articles, webinars, and campaigns, as well as toolkit, print resources, and much, much more. At this point, I've reached the end of my presentation. Next slide, and we will transition to the next presenter.
Thank you, Dr. Hall. Thank you, Dr. Hall, for your presentation. Our next speaker comes to us on behalf of the Association for State and Territorial Health Officials. Dr. Marcus Plesha is the Chief Medical Officer for the Association of State and Territorial Health Officials, also known as ASTHO. In this capacity, he provides medical leadership and expertise across the organization and oversees ASTHO's portfolio of chronic disease prevention and control programs. Dr. Plesha, you're up.
Great, thank you very much. And I'd like to start just by saying thank you very much for inviting me to be on this panel. It's always a pleasure to present to the National Governors Association. And I just have to say, the NGA team is so well prepared. You do such a great job with us as your panelists, so I appreciate that as well. If I could have the next slide. So I'm going to start off, I'm going to spend just a couple of minutes giving a little background to the pandemic and kind of where we are, particularly around this issue of equity and some of the ways that we think we got there. And then I'm going to close out with a slide where I'm going to discuss a few areas that we think we might be able to make some significant improvements. Next slide. I want to start off, before I go into a critique of some of the challenges that we face around disparity and, the disparate measures that you just saw from Dr. Hall and how we've responded to this pandemic. I would like to just recognize, this is an article from when the pandemic first started. The theme, all hands on deck, is still the theme in state and local health departments. They are going as hard as they can, 24 hours, 7 days a week to deal with this pandemic. They are very tired. And I think for the most part, they've done a great job. So I'm going to talk about some things that we can improve on, but I want to place that in the context that I'm actually very proud to be part of the state and local health department support structure. Next slide, please. And this is a article that we did a few months back, and I put the
Dr. Plesha?
yeah, sorry, I just went on mute. Can you hear me now?
Yes, we can hear you.
Yeah, okay, good. So, basically, I'd like to say that, this has been a very challenging time for all of us. But I think that public health has done some things extremely well in this pandemic. We were, despite challenges with testing early on, we were able to get that up and going. Despite challenges with getting people to do mitigation strategies like masking and social distancing, we did, particularly early in the pandemic, manage to get most of the population on board with that, mostly through policies and laws and regulations. We did, after initial problems with testing, get to a point where we have a testing system that's worked well and that's backed up with a fairly strong system that we had to create to provide contact tracing. And then, despite a robust response to the COVID vaccination opportunity, we were able to scale up and do that in a fairly timely and effective manner. So I hope that what we can do is build on some of those strengths and think about how we can deal better with some of the populations that did not fare quite as well in this response. Next slide. This is just, I'm going to skip over this, but just to mention, some of these issues that faced us last spring still face us now. Our leadership and our workforce is dealing with a lot of negative stuff from the public around insults and threats of violence and other issues. Everybody knows about the challenges we face with the variants. But there's good things too. I think people are seeing public health. We're seeing a lot more people interested in coming into public health because they see how valuable it can be. And we've been getting a lot of support recently from Congress and from the President's administration. Next slide. Now, this is just a bit of a segue. Dr. Hall has spoken quite eloquently about the gaps that we're seeing in the type of care and the quality of care and the outcomes that are facing racial and ethnic minorities and people from low income status as compared to everybody else. And I could add to that as we see more and more data about immunization. That's turning out to be also a very disparate process. And most recently with the issue with monoclonal antibodies, which are now in short supply, I think we're also going to see that there's a little bit of a haves and have-nots that's gone on with that as well. So there are a lot of things that we need to take stock in as we think about how we make improvements going forward. Next slide. We do have some good roadmaps about how to do this, and I just wanted to take a minute to lift up a few things. This is the framework that the Institute of Medicine put together to really try to lay out how to implement vaccination in an equitable way. I think we started off trying to follow some of the basic steps that were laid out, but then in the huge demand for vaccination, I think we fell away from some of this and moved quickly to vaccinate the general public when we hadn't maybe taken some of the steps to make sure that we reached some of the populations that are harder to reach in our higher priority groups. And again, I think we can learn from that. Next slide. I will just remind everybody, we came into this pandemic in public health way behind. Public health agencies have not been resourced adequately for the last several decades. I'm not sure they've ever really been resourced adequately. And we definitely felt the strain of having a public health infrastructure that has been under-resourced for a long time now. Next slide. But I don't want to dwell on that too much, because I'm going to shift now to what I hope is a little more of a positive perspective. We have extraordinary amounts of resources coming into public health now from various funding that Congress has put into place. And you can see the numbers in some of these squares here, ending up with, actually, I think that's the second to last appropriation of $25.6 billion. There's money in public health. And when I talk about some of the steps I think we can make going forward, it's not pie in the sky. We now have some of the resources to put these things into place. And I think the onus is on us to take advantage of that opportunity. And the next slide. So this is my last slide, but I'm going to talk for a few minutes about some of the ways that I think we can grow and move forward and really respond better to future pandemics, but respond in a more equitable way to future pandemics, so we don't see these huge disparities like Dr. Hall pointed out in his presentation just a few minutes ago. So the very first thing that I think we need to take into account is that we have to be very focused and clear in setting objectives for what we want to accomplish. Dr. Hall, again, did a great lead up for me, because one of his slides showed there's a substantial amount of money that's going out to states and local communities specifically to work on health equity now. That's the first time I've ever seen that in my career. So we have a real opportunity. I think it was $2.25 billion that's going out to state and local communities. So we have a real opportunity, but if we do what we usually do in public health and try to do everything that it's possible to do and spread ourselves thin, we're not going to be effective. And so what we're really thinking about at ASTO is, what are some core things to really focus on where we can make progress and we can show some success and we can show that we achieve some of our objectives. One area that we think we can focus on is leadership. And as everybody knows, many state and local health departments face challenges in their organizational culture, in their attitudes towards discrimination, and just in the politics of race and racism that make it very difficult for those organizations to move forward. And this is probably the most challenging thing on my list, is how do we equip our leaders to come in and try to deal with that and try to make some of the cultural changes that really are going to be the foundation for any work that we do going forward. The second thing, and here I can be a little more succinct and focused, workforce. We have an opportunity with all of these resources coming into public health to hire and bring on more people. And we need more specialized, highly trained public health leaders, epidemiologists, laboratory technicians. But we also need to look at bringing in a workforce that is known and trusted in the communities they come from. And so I think, particularly the idea of health departments really starting to make more use of and hire community health workers, people who come from the communities that we're trying to reach and are known and trusted in those communities, can be very, very effective in building trust and reaching those communities for some of the kinds of interventions we're putting in front of them. Third thing, community transactions. We've learned that many public health departments coming into the pandemic, both at the state and local level, didn't really have the relationships and the trust built with some of the community-based organizations that I think could be really helpful to us now as we're trying to reach communities of color, communities of different ethnicity, and even low-income communities. We may not always be trusted, but many of these community-based organizations are, and we need to look at ways to build that out, hopefully with some of the funding that Dr. Hall pointed to in his earlier presentation. And then finally, data systems. And, I think this is one of the simplest and most straightforward fixes, and I think it's something that we can make progress in. But it is very, very concerning and disheartening to me that we say we are going to deal with disparities, and particularly racial and ethnic disparities, and yet we don't collect data on people's race and ethnicity very well at all. When we first rolled out the immunization numbers, we learned that only 50% of the information of the immunization records we had actually had accurate race and ethnicity data. So half the people we were doing vaccinations of, we didn't even know what their race and ethnicity could be. So how could we know if we were doing this in a fair and equitable way? We need to fix that. And we have the opportunity to fix that. We have resources to fix that. I really think it comes down to there being a will and strong leadership that that's not something we're going to tolerate in the future. It's interesting to me because we don't have any problems collecting data on gender. We don't have any problems collecting data on age. But for some reason, we have this real difficulty getting good data on people's race and ethnicity. It's a complex, multifaceted issue, but it's one that we have to fix if we really seriously want to deal with the issue of equity, health equity, and try to stem some of the disparities we've seen across this pandemic. So those are 4 very specific areas that I think we can work on going forward, and I'll look forward to maybe having some more discussion about this when we get to the Q&A. Thank you very much.
Thank you, Dr. Plescia. Our next speaker comes to us from Maryland's Department of Health. Dr. Jinling Chan serves as the Deputy Secretary for Public Health Services at the Maryland Department of Health. She leads statewide COVID-19 response efforts and oversaw the establishment and expansion of the state's COVID-19 testing task force early in the COVID-19 pandemic. Dr. Chan, the floor is yours.
Thank you so much, Michelle, and thank you to the other speakers. I'm very honored to be here today with such a distinguished panel, and appreciate everyone who has joined the webinar as well. I'm glad to be able to piggyback on our prior speakers and one coming after me to talk a little bit about how we worked on addressing vaccine equity in Maryland. I think that the topic of equity obviously is something that is a focus for all of us. And, we could really spend a lot of time and need to spend more time really talking about how we implement this. But so I wanted to focus on our vaccine equity efforts in particular, because I think that that really was where we worked really hard to engage communities, but also, had lessons learned. And, it's also how we implemented testing equity and other efforts that are ongoing. So next slide, please. So, with our response efforts, like many other states, we really moved into incident command structure very early under the governor's direction. And by creating that incident command structure and the Joint Information Center, or JIC, that coordinated our efforts in terms of communications out to the public and with our partners across both state and local agencies, was really a foundational effort that I think continues to reap benefits for us. When we first launched our COVID-19 hub site, the data hub, that was a partnership that happened very quickly, and we've been working with them, of course, but it included, of course, our Department of IT, as well as our Emergency Management Office and others across the state. And so that really became a focus for us that we continue to expand on and use to be able to coordinate information about the data, about our messaging, and public messaging as well. And that's really a platform that we use quite a bit to really coordinate that across state and local leaders, and really drives home the fact that that's how we are trying to be data driven in terms of our efforts, and a lot of equity focus and looking at subpopulations within our data analyses. This site has allowed us to be quite transparent and keeping everyone fully informed on the COVID-19 case data, as well as to have this common operating picture, as I mentioned, in terms of what the impact of the COVID-19 pandemic and the vaccination efforts, as well as the progress of our work and where we might need to continue to focus. So this continues to evolve. One of the things that we also developed, and this is particular to our vaccine equity efforts, is that we actually developed a vulnerability index that's similar to the CDC vulnerability index that took into account some of the demographic factors, including race, ethnicity, poverty levels, educational levels, but also looked at specifically the impact of COVID-19, so hospitalization rates in different parts of the state. And we used that to actually build our vaccine distribution infrastructure. And it was part of our strategy to target those efforts towards the equitable distribution of the vaccine. So targeted, for example, some of our mobile vaccination efforts, but it also, this vulnerability index guided how we set priorities for grant funding when we gave out grant funding for hospitals to community-based organizations and others. We really said, we will prioritize people who have a history of working with populations in these areas that show high vulnerability, or show that in their activities, they will be targeting communities in those particular areas across the state. So next slide. So our public outreach and equity campaign, we back in the fall last year, we engaged community partners from across the state, including our Native American communities in Southern Maryland. We don't have a large Native American community, but we did engage them, our African American community, disability community, among others, to discuss our plans for the vaccination campaign. And they were very important to provide input on the messaging as well as implementation and rollout of the campaign, which continues now. We've added the pediatric component and others as we have moved forward in the campaign. And as you can see, we really sought to use voices from across the state, community leaders, physicians, youth, as you can see, the gentleman from one of our high schools here in the state, and others as part of our messaging. And again, back to the JIC that we convened, like other states, they use that, and that was a platform by which we could push out the messaging that we developed. And we encouraged that people use our materials, and they could use them and brand them themselves, and made them easily accessible at the local level to organizations, local health departments, local county governments, and others, to be able to use the same materials across the state. So next slide, one more. Great. And one of the things that we launched early on, the governor launched the Vaccine Equity Task Force back in February of 2020. So early on, as we were seeing and we expected to a certain extent that there would be some differences in how the vaccine rollout happened. And so we launched the Vaccine Equity Task Force, which was under the leadership of Brigadier General Janine Burkhead, with our National Guard. And like many states, the National Guard has been really integral to our efforts here in the state of Maryland. And again, she used and really helped develop this vulnerability index that I mentioned earlier, that helped identify the communities and even the individuals who are vulnerable, underserved, difficult to reach. And the Vaccine Equity Task Force identified organizations within those areas to work with, to actually stand up small vaccination clinics. And on average, you can see that we had 155,000 doses, which doesn't sound like a lot, but those doses are really critical, because on average they were doing about 100 to 120 doses per clinic, which is not what we were seeing in the mass vaccination sites. But we knew that this was an important effort to get into those communities in a way that allowed people access that couldn't reach one of our larger vaccination sites, or didn't want to go to a pharmacy. In addition to some of these targeted vaccination clinics, they made themselves accessible to community and faith-based organizations across the state who wanted to set up small clinics in their own facilities, in their own neighborhoods, to be able to serve those residents there. So throughout our efforts, it's been over 1,100 missions that they've conducted throughout the state. In addition, our Office of Minority Health and Health Disparities with the Maryland Department of Health also partnered with community-based organizations, and I'll talk about that in a little bit. So next slide, please. So some of the tactics that we used, are similar, I'm sure, to what a lot of states have done, but faith-based organizations were really a foundation. Knowing that we have to get down to the grassroots level, to the people who are trusted, and so we worked with faith-based organizations to host vaccination events. They have served as our GoVax ambassadors across the state, and in addition with HBCUs have been an important partner, and we have actually hosted a number of vaccination clinics for those universities, and in partnership where they, with their school health or their services, that they actually, student health services, stood up vaccination clinics. I also wanted to talk about our No Arm Left Behind initiative, which we launched in April as we were able to expand our vaccine eligibility, so that really it was all hands on deck. And this was getting to seniors who may have been homebound, homeless individuals, Medicaid enrollees. We actually did a phone call outreach in which we called every single Medicaid enrollee over the age of 50 to encourage them to get vaccinated, and also to help set up appointments or to get them to work on transportation to get them to a vaccination site that was convenient for them. So on and on, we have a lot of work with community canvassing. So this door-to-door effort has been important throughout. We did that early on in the spring, and that work continues. And we just recently released another grant to community organizations to continue the door-to-door effort, again, focusing on those areas where there is less vaccination, and working on small communities, vulnerable populations in the rural areas, as well as in urban, suburban areas that we're seeing some differences in our vaccine numbers. Next slide. So obviously, vaccine equity, and as we're in across the country, a surge right now looking at access to testing and making sure that there continues to be equitable access continues to be a priority for all of us, and using the data to increase the number of fully vaccinated Marylanders. Across the state of Maryland, right now we have over 95% of individuals who are 65 plus who are vaccinated, and we are at, I believe, about 83% of the population who've at least received one dose. And so we know that there are still differences geographically, as well as in some populations that we continue to work on, which is why we have not let up our efforts around the state. I wanted to touch on, so this is my last slide, next one. And this is important, and I think Dr. Plesha touched on this, is how do we sustain some of these efforts beyond COVID-19? And that is something that we've been thinking about. I mean, we've invested a lot of funding and time and effort, of thousands of Marylanders across the state to building a network with our community partners, other state agencies, local agencies, and others. And so the question is, how do we sustain this and also expand the impact and the work that we're doing with COVID beyond COVID outcomes, and really looking at this in a more holistic way. As Dr. Hall, touched on and expounded on, is health equity, we know, is multifactorial, and it takes a lot of people who may not always be health oriented, but we need partners from across different sectors to engage with us to talk about this issue and to work on it together. And I think COVID-19 has, because of how global it's been and how impactful it is on every single aspect of our lives, using that opportunity, we have brought people to the table that we may not have really connected with before, such as our departments of commerce or labor or others. And, they have been very, very engaged and in so many aspects of our COVID-19 response. And, again, as Dr. Hall highlighted, the disparities that we saw in COVID-19 outcomes and vaccine distribution and others, only highlighted, unfortunately, the existing inequities and disparities that we have to continue to work on. So when we focus our current resources that are available from the federal government and even in our own state investments towards equity and vaccinations and testing and other impacts, the challenge is how we can sustain those efforts beyond our pandemic and also beyond to include other infectious diseases and chronic diseases. So here in Maryland, some of the ways that we're thinking about and working to leverage some of our COVID-19 dollars to actually and efforts to alter the course, hopefully, and change the face of our health equity work is trying to strengthen those relationships not only with other agencies but with some of those community partners that perhaps we did not have a strong relationship with before. Building the community health worker network. And I think this was mentioned before, how important that is as a part of the building up the healthcare workforce and, getting people into the communities. We're looking at how we can, train more nurses, train other healthcare workers beyond community health workers to address some of these underlying chronic diseases like diabetes and obesity that do contribute to COVID-19 risk. In addition, I just wanted to end on this, is that the other example is, we're actually using some of the work that we're doing now with behavioral health populations and disability populations to identify, down to even the person, who's not vaccinated. And we're using that to hopefully expand and begin to look at other vaccinations that are important for these high-risk populations, like for hepatitis A and hepatitis B. And so I think that there are going to be dividends that we can hopefully see and benefits from down the road, but it does take sustained effort from our public health workforce to be able to see those results. So I'll stop there and thank you very much for your attention and pass it back to you, Michelle.
Thank you very much, Dr. Chan. Our final speaker comes from the American Bar Association. Don Hunter serves as the ABA's Director of Public Health Law Network's Southeastern Region Office. Don is an experienced legislative analyst and state health department policymaker and leads work to examine legislation impacting health and racial equity, and to identify and implement strategies to build the capacity of public health agencies and organizations to effectively use law and policy to improve health outcomes. Welcome, Dawn. The floor is yours.
Thank you, Michelle. And I want to start by saying the network is a separate organization from the American Bar Association, but we do collaborate. And so I want to thank the ABA Health Law section for the opportunity to be here to present today. And also thanks to NGA for the opportunity to be part of this great panel. I was recently reminded after 9/11 about the shift in emphasis on policy as a tool to improve public health. And in fact, the Network for Public Health Law itself was established 10 years ago this year, partly driven by the events of 9/11. And so my presentation today is a high-level overview of law, policy, and equity, and not specific legal challenges or issues. I'm a systems-oriented person, and so that's what you're going to see. And so next slide. I hope to leave you with 3 takeaways, and that's 1, that law and policy underlie all outcomes. 2, that attempts to undermine public health can set us back. And 3, that we have to name and specifically address the ways that law and policy create and reinforce disparities if we're going to make progress. Next slide. So starting with the first takeaway, these are from the Morbidity and Mortality Weekly Report, one issue. And these are the top 10 public health achievements of the last 100 years. And I like to share these. You've probably all seen tweets and memes like, do you have polio? Do you have diphtheria? No, thank you, vaccines. Like, I think we've all seen those, right? But that actually matters, because in the 20th century, public health interventions helped to increase our life expectancy by 62%, which is a pretty big deal. And at the turn of the century, we also saw the creation of more health departments and local boards of health. And we also have to remember that today's public health agencies are doing more than preventing, investigating, and stopping the spread of disease and other health threats, but these agencies are also working to prevent injury, promote healthy behaviors, prevent and manage chronic disease like cancer and diabetes, protect against environmental hazards, and address inequities across health indicators. Next slide. So law and policy made all those things possible that we just saw. As of just a couple of examples, we've seen OSHA in the news recently due to federal vaccine mandates, but OSHA actually helped create safe workspaces and mechanisms of accountability for employers. Free school meals, also in the news recently, a critical way to address food insecurity and hunger and healthy child development, and that continues to play a role today. And the USDA recently extended that program through June of 2022. And then master settlement agreement funds, things like harm reduction and breast and cervical cancer screening programs in health departments. And I didn't even know that until I worked in a health department. And I didn't learn that in my MPH program. But I wonder, for all of us who go through those programs, like, what if we had learned these things? Next slide. So the National Network for Public Health Institutes recently issued a report on strengthening the US public health infrastructure. I was honored to be on the technical expert panel regarding public health law as one of the key domains, with the arrow there in the orange. And the findings here were really, there are lots of findings, but related to public health law was one, need for increased awareness among the workforce of the legal basis for public health authority, and self-identified top training needs were how to influence law and policy development and how to understand the effects of law and policy on health. And some of this information comes from the Public Health Workforce Interest and Needs, or Public Health WINS survey. And there's often a disconnect between public health lawyers and the agencies they serve. And those lawyers may not even be trained in public health or even housed within the agency. Sometimes they're the county or city attorney. And so they just may not even have a background in public health. But it is critical to understand the legal basis for all of the things that public health agencies are responsible for and have authority over, so that agencies can make informed decisions and that programs can effectively analyze policy solutions and identify advocacy strategies. Next slide. So understanding how public health touches our lives and how the law enables public health agencies to keep us healthy is really critical at a time when public health is under attack. We recently issued a report along with NACCHO on legislative attempts to limit public health authority by shifting authority in some way or limiting the types of public health orders that can be issued. And several such bills were enacted this year, and at the network and along with NACCHO, we are going to continue to monitor legislative sessions in 2022. And you can access this report online. I will put the link in the chat. Next slide. So I'm in Florida, and so I'm going to share this example, Florida Senate Bill 2006. This bill did a lot of things. It was a long bill, but it also, one thing it did in particular is invalidate any local measure that unnecessarily restricts. It allows the authority to invalidate measures that unnecessarily restrict individual rights or liberties. After this law was passed, the governor here issued an executive order citing this law and suspending local government mandates, and has not issued a new emergency declaration since. So what does that mean? We have increased cases, hospitals and supplies have been burdened. We've had limited access to certain assistance that's available in emergencies, like the Florida emergency mortuary operations, at a time when our funeral homes have been overwhelmed. And facilitating healthcare workers coming in from out of state and working across state lines. And importantly, every legal challenge that occurs to some public health order shapes, and sometimes in subtle ways and sometimes in very significant ways, the legal basis for public health. This includes interpreting new laws like Florida's Parent Bill of Rights, which has been used as the basis for limiting mask mandates in schools, to a series of rulings by the Supreme Court on the Free Exercise Clause that place religious liberty and public health protections at loggerheads. But this new Florida law also does some things that might be positive in the long run, like making public health emergencies subject to the State Emergency Management Act, and potentially allowing for better preparation and coordination across state agencies for future emergencies. It also requires the Department of Health to submit an emergency management plan. It requires an inventory of state-owned personal protective equipment, and it requires medical examiners to certify deaths and to assist the state health officer in identifying and reporting deaths if requested, which, believe it or not, was actually an issue last summer, earlier in the pandemic. Next slide. So legislation, as you can probably tell, I hope you can tell from the Florida example, is often a mixed bag, right, of components that are quote unquote good or quote unquote bad. So there are some good examples, and there are three types that we've seen so far. The first is to improve collective decision-making processes across agencies and sectors. One example there is in New Jersey, the local and county health department infectious disease preparedness study commission, long name there, was established early in the pandemic to assess roles and responsibilities of local and county health departments, communication and coordination with the state health department, and to make recommendations on improving response to future outbreaks. So other states have also looked at establishing commissions or task forces. A second trend we've seen is strengthening local public health authority. Not many, but there are some out there. And one example is in Washington, that established a public health advisory board to the Department of Health that includes community representatives. And in that same bill, it changed the composition of local boards of health to require members who are not elected officials, and importantly, who are in a defined list that includes public health and healthcare practitioners, people with an MPH or equivalent, community health workers, tribal representatives, and consumers of public health. Very important category. And one of the third trends we've seen is increasing transparency through things like reporting and public meetings. One example of that is in Colorado. A new bill requires the governor to provide comprehensive information to the legislature and respond to questions about a current disaster emergency. And I've seen this portrayed as a limitation, but frankly, being transparent about decisions that impact the people you govern is a good thing, in my opinion. And so we hope to see more bills like these three in 2022. And I apologize if you hear my dog in the background. Next slide. So for this last section, I'm going to talk about racism in public health specifically. You may have heard of the 3 levels of racism, and some models have an additional level, which is the individual level. But the important thing is identifying and recognizing the levels and the way that they operate in our lives. So at the interpersonal level, that's between individuals, and that might be the way physicians treat Black patients' pain differently, which has been a factor in the opioid epidemic, or disregarding concerns, which happens with mothers of color and is a contributing factor in our maternal mortality rates. At the institutional level, how does this manifest? A study in Florida of 1.8 million births showed that Black babies are more likely to die when cared for by white doctors than when cared for by Black doctors. That's an institutional issue for many reasons, one of which is that there aren't enough Black physicians. And that's also a structural issue because the lack of Black physicians today can be directly tied to systems like barriers to higher education and the closure of Black medical schools in the early 1900s due to the Flexner Report. Next slide. So we see all of these levels operating when we talk about infant mortality in the United States. The US has appalling infant mortality rates for all infants, but in particular for Black and American Indian infants, which you can see here on this slide. And that's due to some of the factors that I just covered at the individual levels, the different levels of racism. Next slide. But we know there are some things that reduce infant mortality rates. Law is an important factor in that. And so civil rights laws, Title VI of the Civil Rights Act of 1964, along with other civil rights legislation that was enacted at the time, significantly reduced infant mortality in the years after it was enacted. And then we see another significant reduction in infant mortality when the Affordable Care Act became law, in particular in Medicaid expansion states. We also know that public health laws like mortality review committees are also important. But why do we need laws? A good example is from my home state of New Mexico. New Mexico has a law on the books that allows for the health department to establish mortality review committees, and actually drafted regulations in the late 1990s for a maternal mortality review committee. But one was not successfully established until 2018, when a committee then met and reviewed deaths from a few years prior. And so in 2019, a bill specifically creating a maternal mortality review committee, along with roles and responsibilities, passed the legislature. So one of the many lessons there is that sometimes the law needs to be explicit and sometimes it needs to be mandatory rather than permissive. Next slide. So what are some current legislative trends? There is a continued focus on equity in birth outcomes. So example, you might have heard of North Carolina had a Momnibus Act. I think several states actually had a similar bill, and there's a federal one as well. Data collection and use, you've heard us talk about that. Provider education and training, lack of cultural competency requirements for healthcare practitioners in most states do not require cultural competency for licensure or relicensure. And I'm going to talk about the two with stars very quickly: declarations of racism as a public health crisis and task forces as part of infrastructure. Next slide. So more than 200 declarations of racism as a public health crisis have been introduced, considered, adopted, and in some cases rejected across the US. At the network, we have analyzed these across regions and assessed the operative statements, or what these entities actually resolved to do. And these are an important first step in naming the problem and then committing to future action that takes a public health approach. So changing systems and structures and looking at law and policy as a root cause, and recognizing and addressing disparities in the social determinants of health. Next slide. So you heard Dr. Chan talk about leveraging partners post-pandemic. These are some of your partners, not just government entities that have issued declarations, it's professional associations, insurers, hospitals and health systems, and universities. These are partners, these are key collaborators, they are conveners, and importantly, they can also be funders. So one of the questions to be answered is really what can be done collectively to address racial and ethnic health disparities. Next slide. Another thing that we've done at the network is analyze COVID-19 health equity task forces that have been in response to the data that you heard Dr. Hall talk about. We have a publication pending that covers an analysis of 25 task force reports that were issued, and we read them all. And this map also actually includes Georgia and Mississippi, which were not in our original analysis, but were in a did subsequently establish a task force. And this does not include states like California, which is doing a great job of integrating equity throughout government, Texas, which has committed to doing some studies on disparities, and New Mexico, which has a racial justice commission. Next slide. So these are the key issues and policy recommendation areas from the task force reports. That publication is not yet out, but the most important part, arguably to me, is implementation. So funding, staffing, and accountability. I will also note another article that recently came out, because you also heard Dr. Chan talk about the vaccine equity plan. And there was an evaluation of health equity in COVID-19 distribution plans in JAMA Network Open that found that most states failed to engage a health equity committee in developing their plans, and that people of color were only representatives in 16% of all reported vaccination plans. So it's not enough to have a task force if your task force isn't inclusive of impacted community members. Next slide. So to revisit my earlier slide, recommendations by task forces in declarations or from other sources should address the various levels of racism and how law can make a difference. So what does that look like? At the interpersonal level, provider education and training requirements, implicit bias, cultural competency. At the institutional level, increasing workforce diversity through your HR policies, or incorporating community feedback into programming and investment decisions. Structural level, improving your public health infrastructure. We've been talking about that. Identifying and removing legal barriers that impact access and opportunity. Next slide. So I'm coming to the end of my section. I know I have like 2 minutes left. So in practice, this is a good recent example of what that can look like. The Washington Post published a detailed account of FEMA's policies in July, noting that FEMA regularly denied claims to Black families who live on land that is passed down informally between generations, which is a relic of Jim Crow. And it's commonly known as heirs property, but basically it's where property is passed without a will. And FEMA required proof of land ownership in the form of a deed or a will. But about a third of Black-owned land in the South is actually held via heirs property. So this recent policy change actually allows more options to provide proof of ownership and reduce barriers to federal disaster relief funds for Black families. But it also affects Hispanic people, for example, in the Colonias in the Southwest, American Indians, and rural white people in Appalachia. Next slide. So this is my last kind of big summary slide. And I think this slide captures all the things that you've heard all the presenters talk about, but how do we use the law to create more equitable outcomes in the future? We can formalize our actions through legislation, but also through regulations and ordinances and organizational policies, making sure that we take, that our laws are informed by data and evidence and subject matter expertise, actually reviewing them through an equity lens, putting resources, including people and money, and really emphasizing the role of budget as a policy tool. One of the most important, if not the most important, is engaging communities in the policymaking process and equipping community members to lead, and then monitoring the impact of laws and policies on health outcomes over time. So my last slide is this. I think these things are important for the next slide, are important for long-term sustainability, and that's acknowledging our history, drawing the connections to problems that exist today, building relationships and crafting solutions with impacted people and people with lived experience. And also acknowledging that the work for racial justice has been going on a long time. It was highlighted by the pandemic, but people have been out there doing this work for years, decades even. And so I think it's important to recognize that and to align with the work that has been, the groundwork that has been laid, and taking the next steps. And I think really having a better foundation for public health emergencies means that we start with having a better foundation for public health. So thanks again for the opportunity. I look forward to questions.
Thanks, Dawn. Thank you for your presentation. And thank you to all of our presenters for your presentations. We really do thank you for all the work that you continue to do in this area. We will now move on to the question and answer period. If you have a question, feel free to drop it in the Q&A function or the chat function, and we'll get to them. I see that there are a few questions and a few attempts to answer questions. I think one of the questions that was attempted to be answered should be amplified for the larger group. So I will just go ahead and answer that question. It would be interesting to get some data on the number of individuals with disabilities who experience COVID-19, including deaths, as these individuals intersect with all ethnicities and races. So I assume the question is that something that CDC and others are working to collect? Does anybody want to answer that question? I think Dr. Hall, you might be the best person to respond.
Good, put the spotlight on me. No, seriously though. Yes, this is a current topic of conversation, and I don't mean to make light of that with the way that I just came in. One of the things that we are aware of, as someone mentioned, is that the challenges to collection of data for persons who are disabled are parallel to many of those that have been noted with regard to the collection of data on race and ethnicity. But as you might expect, there are also some unique factors that contribute to this situation. So as a case in point, there are points of contact through which people wind up getting counted in some of the systems that are responsible for surveillance information. As a case in point, the point of contact that comes to mind include those where people wind up getting COVID tests or points of access where healthcare is concerned. And in a lot of situations, there may be conditions at play where persons with specific forms of disability may be less likely to be able to access the testing spaces or to really gain access to some of the context for healthcare. And as a result, when we look at some of the surveillance estimates that are out there, there may be undercounts. In other words, there may be some limits with respect to what we do see in the system. We also know that at the state level, there are a variety of different reasons as to why data on disability, like data on race and ethnicity and other variables, may be challenging to collect. So yes, this is something that is of concern to us. We are trying to take a look at this as well as to obtain additional information for other key social variables.
Any other speakers have anything to add to that? Okay, moving on in the same vein as surveillance and data collection, our next question is, the very nature of many ways states and localities implement public health interventions is often thought of as a key feature of our public health system and appropriate exercise of the 10th Amendment police powers. But much of this is often discussed about challenges created by the 50+ different public health surveillance systems, including shortcomings in collecting race and ethnicity data. Do you think there'd be an appetite for mandatory public health surveillance system that would replace state disease and syndromatic surveillance systems that could, among other things, ensure race, ethnicity data is collected and used in investigations and response. Maybe Dr. Plusha and Dr. Chan might weigh in from the state perspective.
Sure, I'll start off with that. I mean, I think that we don't really need to have a complete sort of redesign and development of a federal data system because we have so much infrastructure. I think it's important to not lose sight of, despite the inadequacies of some of the state and local IT systems, there is a lot of infrastructure there, and there are things we do well. I mean, birth and death certificates are a good example of a system that I think works relatively well. So, I think we can take that system and make it work better. And we do need to make it work as a system that serves us as a nation. And that is one of the challenges with having these 50 different state-based or federalist systems. And so I think probably my response to that question is we need something in between. We probably need a little bit more federal oversight and federal regulation around certain requirements. But I think continuing to use the infrastructure that exists probably makes sense from a resource point of view.
Yeah, I think that if I could piggyback on Dr. Plesh's comments, I agree. I mean, there's a lot of work, of course, that the states have been doing, and even prior to the pandemic, of course, in terms of how we collect data and such. And, I think at the federal level, it is about standardizing data collection, including on race and ethnicity, I think would be extremely helpful because, we've seen some, differences in how data is collected and reported. And so that can cause some confusion and perhaps not as good understanding from a national perspective on the impact of, whether it's COVID or any other disease on the population. And so I think that there is work that the CDC is doing and that the states are also doing that will invest in, this is the data modernization initiatives to modernize our public health data systems, which are greatly needed. And I think a lot of that will be about expansion and integration, perhaps with other health systems and then with other states using some of our existing infrastructure.
Dawn or Dr. Hall, do you have any perspectives?
Yeah, I just want to kind of echo what Dr. Chan was saying in terms of enacting basic data standards that would be applicable across the states. It's something that would be a first step. And it's actually a very common recommendation from the COVID-19 health equity task forces across the US. And it's also not uncommon to see it in some of the declarations of racism as a public health crisis, which also suggest improvements to data collection, use, and reporting. And then to add on to that, to look at ways to better collect data on the social determinants of health so that hospitals, health systems, clinics, health departments, et cetera, are looking at the whole person and their needs as they take into consideration programming decisions, budget decisions, et cetera.
Any other? Dr. Hall, I saw you come off mute real quick.
Yeah, I think we're all sort of singing the same song in different registers at this point. The only thing I'd add is, of course, another part of the conversation involves the need for, technical improvements to race and ethnicity data collection, but also a backdrop of that often gets left out of the conversation is that at bottom level, a lot of people, a lot of persons, a lot of populations are still hesitant to provide information about race and ethnicity because some have indicated that there are fears about how such information might be misused. And so part of the work that is embedded within our labor at this point is also how do we, sort of crack the fears around the use of that data? How do we go into the spaces where mistrust and distrust exist and can be amplified when someone is feeling ill to be able to allow them to feel more confident that this information is not just going to help them, but also helps us to figure out if there are patterns of specific needs that exist by population.
Thank you. Our next question is for Dr. Chan and Dr. Hall, I believe. Thank you, Dr. Chan, for highlighting the need to leverage the discussion on equity in COVID response to enhance the discussion in other public health areas. How do you mitigate the risk that the discussion is tied so closely to COVID response that when response is done at some point, that the conversation around equity will stop along with response, especially in the minds of the public?
No, that's an excellent question. That's exactly the, what we're concerned about. And, I think that with the funding that we've received and, any flexibility with that, because, we want to look at not just, the COVID response and, that focus is incredibly important, but understanding that, as Dr. Hall alluded to in his initial remarks, some of these disparities that we have seen in terms of the impact of COVID, really have more to do with longstanding inequities regarding, access to care, regarding racism, regarding social injustice, regarding underlying conditions that perhaps are not addressed within our current health system. And so that's why we're trying to use our efforts and our dollars to, see how we could leverage them and engage community organizations to help address some of those efforts. So this is, what I alluded to. And that's, I think, the way that the path towards at least sustainability, not only of the conversation, but of the efforts that we have to build on. I mean, we're always looking to build and not to build and then tear down. And so that's definitely the effort here, and I'm sure nationally as well.
Dr. Hall?
Yes, I'll just add to the conversation. So one thing that there's a couple of sayings that we currently try to put out there as much as we can. One of them is to remind people that COVID is just the latest manifestation of systemic inequity, right? There are people who've been laboring, in this space for decades. And, while COVID is the spotlight that has unearthed and exposed us further to the darkness that surrounds these inequities, we fully intend to use that spotlight to make sure that this moment allows us to infuse health equity into systems and structures in ways where we try to, as best we can, significantly reduce, if not eliminate, gaps between population health that result from, these systemic inequities and systemic, challenges that exist. One thing we also talk about, to not just focus us on this moment, is to, think about not just this idea of getting back to normal. We're all trying to go outside. We're trying to resume normal life. There are some of us that are trying to use this moment to get beyond normal. And by getting beyond normal, we mean that we have to focus the conversation on creating a society that is better and that does better by all. And that includes expanding access to vital conditions for community health and well-being, access to basic safety, access to safe, stable, and beneficial workplaces, things like that are a vital part of having a healthy and safe life.
Thank you, Dr. Hall. And Dawn?
Yeah, I want to add to that. I think that's what I was trying to get to at the end of my presentation, is that people have been doing this work for a long time. And even where we have had declarations of racism as a public health crisis in response to the murder of George Floyd and racial justice protests that occurred over the last year, in some cases, declarations came from years of work and advocacy to make them happen. And then my other point that I always like to mention when I can is that states have had offices of minority health, state offices of minority health, or health equity. They have different names, but there's this network of offices who are associated with the health departments in each state, and they are not all funded the same. They are not all staffed equally. Some of them are understaffed and underfunded or not funded at all. And so, when we think about like long-term sustainability of this effort, it's like, let's invest in the infrastructure that we have and build people up and support the work that people have been doing, and then align them with some of these current movements and momentum related to COVID. So I just wanted to add that.
Thank you, Dawn. Those are important points. My next question is for Dr. Chan. This is critically important, especially in this time when we're having a lot of different issues happen across different states around messaging and trying to get unified messages, even at the federal level, surrounding COVID response. So it sounds like there was a unified response across your state from the governor, the state and local emergency management agencies, and public health officials. How did you achieve that? And are there any tips or suggestions that you would advise for other states?
Well, and it's an ongoing effort and requires work, and it's not always easy. And we know that in the landscape that we're all operating in, that there's a lot of differences in terms of opinion and approach. But early on, as I said, we established our incident command structure, and inclusive of local agencies and local county executives and municipal leaders, and a lot of communication with them, and providing resources on the communications front. We have very regular calls with our local health departments, but also local health department communications officers and PIOs, and that I think is at least part of it. And working towards a common, that common operating picture, as I mentioned, regarding starting from our data, sharing that information, sharing the analyses, was really important to making sure that we were as unified in terms of our focus. We are looking at ways, of course, that we could improve that, and but those are some of the things that we did to try to unify the work across the state.
And Dr. Plesha, I don't know if in your work you've identified any other states that you thought particularly did a good job at collective or cohesive messaging around these issues. Would you like to discuss that or provide any kind of insights on what you're seeing?
Well, they're all doing a fantastic job is sort of the party line, and I think that is true. We're lucky to have Maryland on the panel with us because I think they're doing a fantastic job. Somebody, I think Dawn mentioned some of the work that's gone on in North Carolina. That's a southern state where often this work is particularly challenging. I think that health departments that have traditionally had a lot of resources and attention, like Washington State and New York State, have also done fairly well on this. I mean, some of it, I think they've all made some substantial contributions. It's just, you have to kind of put it into the context of what their environment is and what some of the challenges are they're facing.
Understood. And then we have another question in the chat. One of the challenges I think we face is around accountability. We have support to initiate conversations, collect data, and monitor impact. However, we are continuing to see challenges with accountability. Any recommendations on what healthcare organizations can do to hold partners accountable to continue pushing for improvements in public health equity? Any of the panelists want to take that on?
I'll make a first quick comment since I held forth a bit about the need for more complete data. I mean, the real point there is, you really can't hold people accountable or institutions accountable if you don't have good data. And so, I think we do have to start with that. And, there's this saying, particularly in clinical work, that what gets measured gets done. And so I think beginning to have better data helps us develop more accountability. Now, the two other things about that, I mean, first of all, there has to be a policy approach to this, because there has to be a level playing field around data collection, particularly sensitive data like this. Right now, if you're a healthcare institution or another group trying to really pay attention to health equity and measure that and hold yourself accountable for that, I mean, you're at a competitive disadvantage, because you're gonna find problems and you're gonna get a lot of negative publicity for those problems. Meanwhile, another place that doesn't bother to be transparent about those things doesn't get any negative publicity. So we need a level playing field where the data on these issues is easily accessed for everybody, so that that there's not a competitive disadvantage. The other thing that is really challenging around this is we need some kind of way to better define these measures. And there was another question I saw in the chat about, how do we define race and ethnicity in our question set so it's done in a fair and acceptable way, and also so that respondents feel comfortable in answering those questions. And I think that's something we're just going to have to hammer out within public health and come up with some ways of categorizing it that are acceptable, maybe not perfect, but acceptable for everybody, so we can at least make some progress.
Thank you. Dr. Hall, did you want to weigh in?
Yeah, I will. I just dropped some things into the Q&A that will do a better job of what I would like to mention. Embracing an anchor mission at an institutional level when that's possible is one strategy that some institutions have engaged. I dropped in a few leads to some of those. For example, Rush University Medical Center, Bon Secours in Baltimore. Those are a few of the institutions that have sort of said, we're an economic contributor to this community. We have connections to the life of the community. We are of this community, so we're going to do our best with the weight of our presence to push to create conditions in communities that will promote thriving. So that might be one way that this influence that is mentioned could be exercised.
And Dawn, I saw you wanted to weigh in.
Yeah, I have a couple of things to add. The first is that accountability goes both ways. So it's not just about health departments holding partners accountable. We need to hold health departments accountable and hospitals and health systems as well. A couple ways we can do that are, one is that creating shared vision and goals among partners. So there's some joint accountability or joint progress that can be measured. Establishing dates and timelines sounds simple. We hear about that, in our own work days. You need to have SMART goals and et cetera, et cetera. So do people who are working toward racial equity, like, what's your actual plan? When are you going to achieve it? And having public reporting. So whether that's a public dashboard, regular reports to the legislature, whatever that looks like, having some way of communicating back to the public whether or not you're making progress. And it's important to also note when you're not, because that's also being transparent and saying, we're doing the work and we're not where we want to be, and that's part of continuous quality improvement. The other thing I would say is that it's important to look at how you can then enshrine some of this through regulations and ordinances. So it's not just about passing new laws with the big L, it's about the regulations and ordinances that impact our daily operations, like in our cities and counties. And so looking at how we can enshrine some of this work, like requirements for our workforce, that will help to improve diversity. And the other, one example I'll give of this is Buncombe County, North Carolina. Recently, the Board of County Commissioners approved a racial equity action plan. It has been developed over the course of the past year with community input, with workforce input. There are very clear action steps. There are timelines associated with it, and it was approved by the county commission. So, there is some force behind it. There's buy-in from partners around it, and it's very clear how everyone who's involved in trying to improve and advance racial equity in Buncombe County, everyone has a role. Everyone has a role, and everyone's clear on what their role is, and they feel, I think a lot of partners would say that they feel engaged. And so thinking about a process that is inclusive and has clear mechanisms built in to ensure that those goals are met.
Thank you, Dawn. Well, Dr. Hall, Dr. Plesha, Dr. Chan, and Dawn, thank you so much for giving us some of your valuable time. If you have any questions or would like to follow up with our speakers, please feel free to contact me at mwoods@nga.org. This marks the end of today's webinar and our webinar series on equity and policy preparedness during public health emergencies. A recording of today's webinar will be posted along with the others in the webinar series at our NGA's website. Thank you again to our speakers and the audience for your participation. Please enjoy the rest of your day.